Dear Chairman, ladies and gentlemen, first of all, I want to excuse Professor Špinarová and Professor Špinar. They were very sad that they aren't able to come in here to this meeting, to this great meeting. And my topic is the prognosis in heart failure and in relations to NGAL and NT-proBNP. We focus on our registry, which is called PHAR-NHL, Pharmacology and Neurohumoral Activation, and from the registry of chronic heart failure with patients with lower ejection fraction than 50%. They should be at least 1 month stable. And there were included patients in 3 cardiological centers in Czech Republic, in Brno and Prague. This is our flag of Czech Republic. And as well, other institutes from Masaryk University, like biostatistics or lab samples, were processed in these departments. From 1,100 patients that were included into the whole registry, we excluded patients without available follow-up data, and then without available samples of creatinine, NGAL, or NT-proBNP, and we've got 547 patients. And then we look for the follow-up. The primary endpoint of this study was all-cause death combined with left ventricle assisted device implantation or autotopic heart transplant. And this primary endpoint was present in 13.5% of patients. When we focus only on all-cause death, it was present in 11% of patients, and new heart or the new pump get 2.6% of patients. What is NGAL? NGAL is neutrophil gelatinase associated lipocalin. It's protein. And its expression is upregulated. That means it's higher when is present acute kidney injury, inflammation, ischemia, or infection. And it's not only renal parameter, it doesn't predict only mortality, but as well it is the overall marker for the level of severity of, in general, cardiovascular disease. Let's focus on baseline characteristics. In our registry, there were 80% of men, age approximately 62 years old. Half of patients were with ischemic etiology, 40% dilated cardiomyopathy. Almost 2/3 of patients were NIHA class 2, and the average ejection fraction of left ventricle was 35. And here's the table with association of NGAL. And as we've said, the level of NGAL is higher when the patient is more severe. And so it was statistically significantly higher when the patient was older than when the patient has atrial fibrillation or stimulated rhythm, was higher when the etiology was ischemic of heart failure, definitely was associated with NIHA state. And in heart failure, we know there is a blood pressure paradox that higher is better. because we can titrate medication, and so this association was shown in here as well. So when lower blood pressure was present, the NGAL was as well higher. Here we have laboratory parameters associated with NGAL. NGAL was primarily like renal parameter, so it's obvious that it's higher when urea or creatinine is higher, and as well it's associated with creatinine clearance, but it's as well higher when the albumin or hemoglobin is lower, and as well it's associated higher NT-proBNP and higher NGAL levels. Here we have distribution of NGAL and NT-proBNP. NT-proBNP is in here, and there was statistically significant difference between patients with no endpoint and with present endpoints, and of course patients who were more severe were with higher NT-proBNP, and there was statistical significance of NGAL in both these groups. As we can see, the area under the curve of NGAL is very low. It's only 0.6, but from this receiver operating characteristic curve, we took the cutoff value, and then we've divided the patients into two groups, and you can see, according to the cutoff value of 90 nanograms per milliliter, there is significant difference between survival of patients without primary endpoints, and it is almost 20% of difference. This is graph as well, survival without primary endpoints, but to the NGAL we've added NT-proBNP. And here we have the best survival, 90%, when NGAL and NT-proBNP obviously were lower than cutoff value. Then the worst survival was the opposite. That means NGAL and NT-proBNP was higher than cutoff value, and in the middle there are two curves that one of them is higher and one lower, and you can see that between those middle curves there was no statistical difference. So maybe it is the same that one of them is higher and one lower. We can, from this graph, from chronic heart failure, we can compare with another registry which gives us very similar graph, and I can see here the author, the Alan Meisel, who was here a few years ago, and his registry Gallant of acute heart failure, and the colors you can see is almost the same, only in acute heart failure, so very similar graph. Let me conclude. NGAL has an independently very poor ability to predict our outcome, like death, hospitalization, LVAD, or orthotopic heart transplant. In conjunction with NT-proBNP, identifies patients at risk for heart failure, but in heart failure, definitely NT-proBNP is very and most important for prognosis setting. NGAL is not only a renal parameter, but its values are elevated in other comorbidities, And as we've shown, the paradox of high blood pressure was confirmed. Thank you.
Thank you so much, Karel. Now we can open the discussion. In the meantime, people are thinking for a question. I have a simple question for you. Which is the additional value from your data of NGAL to creatinine? Because at the end of the day, you say that there is a linear relationship between creatinine and NGAL, and then you say that NGAL was an independent predictor of mortality compared to creatinine. But I am thinking that if you are inserting NGAL and compared to creatinine, did you make this difference? How NGAL is performing better than creatinine?
When you take creatinine, its level is in blood with 1 or 2 day latence. That means their values are higher after 1 or 2 days after injury of kidneys. But the NGAL is very, very acute marker, so you can maybe monitor by NGAL the acute injury of kidneys. So
okay, I was just wondering about the prognostic value. I understand AKI role of NGAL. Any other question from the floor? Okay, because another issue is that Frank, you were making any question? So just another issue is, we're finished. You are perfect in time. The only question is that you should probably look about the false positive value of NGAL in the patients having chronic disease. Like we recently published a big meta-analysis. So there is a challenging on the NGAL that still should be addressed. But this is out of your presentation. Thank you very much.
Thank you.
Thank you. The next speaker